support unit and at SickKids. Essentially, I am an embedded patient engagement specialist here to support all researchers across Ontario that are doing research in child health. So I work here at SickKids specifically to advance how we do it here, but my ability to support researchers spans for everyone across Ontario. So I'm going to share some of my experience and expertise with you to help you develop a patient engagement plan. Now, I don't know what your experiences are in patient engagement. If you're just hearing about it, you think it's really cool. If you've been doing it for a while, or if you've taken a couple of courses on it. But this is going to target everyone who spans that entire spectrum, because what we're going to try and do is talk about a little bit about what the value of patient engagement is. I'm going to share with you my perspective on value as a patient and family advisor. I think that's a voice that's not often heard. And then we're going to think about how we can choose our methods in terms of developing a patient engagement plan. Then we're going to figure out how to kind of piece all those pieces together in terms of why we want to engage, how we want to engage, and you know, what resources we have to do that. And then I'm going to put you guys all into groups together to work out a patient engagement plan for yourselves. So as we do our workshops in the end, you can either work on a project that you're working on or build and help a colleague on a project that they're working on if they're a little more advanced and they're thinking about their patient. So we're going to integrate through our sessions. I'm going to have you do some work, and then in the workshops, you get to work together. So I'm going to ask you if you're online or in person, if you have your computer, pull up a Word document so you can type stuff out. If you're old school like me and you want to pull out a piece of paper, pull out a piece of paper. We're probably going to need about a couple of sheets of paper just to note stuff down. And that information is what you'll use in your workshop when you work with each other at the end. All right, let's start with the basics. What is patient, family, and community engagement? And I put this definition up because over the past few years, engagement as a general term has changed a little bit. We think of social media engagement. How do you get clicks? How do you get people to come in? That's one form of engagement. But when we're talking about here, when we talk about patient, family, and community engagement in research, it's about meaningful and active collaboration in the area of government's priority setting, doing research, and knowledge translation. And I bolded the words meaningful and active because that's what differentiates it from kind of social media engagement, just getting the clicks. It's just not a one-sided thing where you present something and you hear something back in a emoji, you know, a thumbs up, a like. But it's really that back and forth that builds meaningful engagement. It's that back and forth of active collaboration that we're aiming for in the work that we do here. Here's another definition that comes from academia. So Carmen is a prolific researcher in the area of patient and family engagement. The definition is patients and families working in active partnership at various levels across healthcare systems. That can be direct care, organizational design, governance, policy making, and all of that with the aim to improve healthcare. So again, I bolded the words here, active partnership, because that's really what we're aiming for. And when I say active partnership, this is what kind of differentiates us from maybe some older methodologies that are still very useful, but you know, focus groups, things like that, where researchers take the information, then go into a back room and, you know, process it with your colleagues of researchers. That's one way to get input, but that's not that active collaboration. That's not the back and forth that we're looking for real meaningful engagement. So, you know, qualitative methods, interviews, focus groups, workshops are great, but we're going to try and incorporate those sorts of methodologies with methodologies that kind of work towards more of a back and forth collaborative engagement. First question I have for you is to think about, why do we engage patients and families? Why is it important to take sometimes an extra couple of steps to, reach out into the community and find out what they're thinking? Anyone have a quick answer that you're willing to throw out there on why you engage patients and families?
By understanding the needs and priorities of a group or a community, you can conduct more relevant and meaningful research.
That's fantastic. That's one reason. Any others? There's a lot of them, so there's no right or wrong answer here. You have a different?
I would think that.
Yeah.
I think like strengthen your knowledge translation as well when you're working with people or figure out ways or tools that are relevant for it.
I love that. The other thing that builds on that is it kind of speeds up the uptake of research, right? So if you're engaging people early, then you don't have to do a study at the end to figure out, oh, why isn't this working? So that speed to uptake is kind of really important. Anyone online while we're waiting?
They're the ones who will be most likely impacted by the research the most.
Yeah, we can be all theoretical. We can do our research in our own bubble, but if it does not involve the people that are going to be the end users, then what do you really do? Anyone online want to share why engaging patients and families and community members is important?
We have somebody typing, but they're welcome to speak also.
While you're thinking of it, I'll give you one of my answers. So one of the reasons that we do it is it just adds extra context that you might not have access to as a researcher. You can do all your literature reviews, you can do your scoping reviews, you can do your gap analysis, you can do all that stuff. But sometimes it's just talking to the patients and families that'll give you insights into stuff that you would never know. So this was posted on Twitter, X, whatever we're going to call it now, to say that an estimated 1.3 million adults in the United States are in guardianship arrangements. So guardianships means that you have someone, I think Britney Spears might be the prime example of what a guardianship is, where someone else has control of a lot of the decision making that you're making around money, healthcare, those sorts of things. And 1.3 million adults seems like a huge number. What are we going to do to solve this? What are we going to do to service this group of clientele? But patient and family, or actually someone who works with patients and family, added, and now Twitter has community notes, so maybe this might be a community note, but the idea is that guardianship, yes, might mean that the person under guardianship needs the supports of someone else to help guide them through decision making. But also, you might not get supports unless you're under guardianship. And for many patients and families, the supports are more important than the decision making authority that comes with guardianship. So understanding that distinction of, we think there's a pathway to something, but that pathway might actually be a workaround. You might not have insights into that workaround unless you're talking to the people who have to do the workaround, because that's how it's meaningful in their lives. I'll give you a funny one. Why do we engage patients and families? Because sometimes we just don't have the same view. There is no way. And the researchers are the parents on the left-hand side. Everything looks perfect from your point of view. But did anyone take a minute to look at what the baby's point of view is? Is it even possible for you to consider what the baby's point of view is in there? And it's not saying that you're doing anything wrong. It's just that you don't have the ability to lie in a crib and look up. Right? You don't have the awareness of what it would take to maneuver this mobile in a way that you would have their point of view. Sometimes we just don't have access to it. There is no way that I can have access to walking through the world as a man. There's no way I would have access and understanding how that experience engages with those people and how it builds them up to who they are. And that's all we're saying is that means you have to talk to them. That means you have to engage. And it's not enough to just interviewing, it's really trying to figure out, and this is one of the challenges that I like showing this graphic for. The challenge is, how do you get the baby to tell you what they see? And then, if they told you what they saw, would you believe them? That is the challenge that we're going to try and address when we talk about patient and family engagement. And that is the challenge I want you to keep top of mind when you're thinking about the methodologies that you're going to put together to come up with your patient engagement plan.
Just 2 comments coming in from online. I assume when we engage patients and families at the end, we could have more accurate and reliable data. And the second, it is crucial to actively listen to the perspectives of both caregivers and patients, ensuring that our work and research are specifically designed to effectively meet their needs.
Perfect, exactly. However, theoretically, saying it is much easier than doing it. So I think that's what we're going to talk about today a little bit and give you some time to reflect on if you're doing it in a way that is getting you the insights and if you're doing it in a way that works with the way patients and families want to engage with you. So just to add to the list, thank you for bringing up a couple. You know, it adds context. So you say, you know, I never thought of that. I didn't see that. We're in a meeting where people were talking about using patient stories for marketing and things like that. And the patient came up and shared the feeling of what it means to share their story and what it is like afterwards to decompress after sharing such an important story. And the person that was using the story said, oh, I didn't even think of that. I just thought it was like someone going up there and giving a presentation like every other day we do this in academia. I didn't even think about the emotional toll it takes to share a personal story. So that is just from conversations. It was only because we were in a meeting that they had access to that information. Oh, my spelling error on there. It makes applicable to users, so communities feel, not fell, communities feel, so you get that insight. Depending on how you engage, you get that honest insight. Focusing on meaningful outcomes. So you could do an entire research study that tells you this is the best drug in the world. And then the patient says, I don't take it because. What does all that research do if you can't get it into the hands of people and their actions? So understanding those sort of interactions that only come with the intersectionality of that patient is what can help you inform what you're doing in your research. It increases speed and uptake. So like we said, if we understand what the user needs are at the beginning, we can meet the user needs at the end. But it's that interaction, that collaboration back and forth that happens during the research study that helps us understand those user needs in context. So a focus group, an interview is fantastic. But then when you start bringing in other pieces of information, if you just take those and bring them together, you might not have that back and forth that comes with like, oh, but this happens and then this happens and then this happens. You're just going to take, you know, static data, apply it to your other data and hope you have a really good analysis. What we're hoping for in engagement is that that back and forth happens and you kind of negotiate your outcomes together. And in the end, it's really about improving health outcomes. That's what we want to do. That's our goal. That's what we're all here listening to me talk today is to improve health outcomes. Now, there are practical considerations as well in terms of why we engage patients and families. If you're doing a clinical trial, you want high recruitment numbers. You can engage patient and families to understand what the barriers are for them to participate in a research study. Do they not understand the consents? Are they too confusing? Are you not reaching out to the right communities? All those can come from insights from patients and families. You can have communities help support you in terms of sharing your study so that they reflect through their personal experience why the study is important. I can tell people as much as I want how important the study is, but if a community member goes into the community and says, no, I've spoken to these people, I trust them, I understand what they're doing, I think this is really important, they can talk to them at that level, and that's what insight you can get from engaging with patients and families and partnering with them. You can get easier processes to participate. You know, a simple example of that is you know, people say go to the patients where they are rather than asking them to come to you. So, you know, if you can figure out a way to bring your research to a community, then bring your research to a community. But you might need to talk to people first in that community to understand how to get in safely, how to do it effectively, how to do it with meaning and community support. But, you know, that is an easier process than having to recruit people through a poster and then asking them to come to some random meeting room in the PGCR. We get diversity in recruitment that we can do through engagement. That means in the research I do, I work with children with medical complexity. Often all I hear from is moms. My goal is to reach out to those that don't speak English and dads. Those are my two goals often. And if I can get one dad, I can get two dads. If I can engage with two dads that can give me different perspectives on things, then I might be able to engage four dads. That helps me do research better. Now I have different perspectives in my research study. We want patient-informed consents. We want sharing of findings. So we talked about knowledge translation and getting things out there. There is nothing better than knowledge shared through patients and families themselves. They know the people that need to be targeted. They don't even need to do a research study on their target audience. They know their friends, families, and other parents that are dealing with the same challenges they are, and they get the research up to you really fast. So this is what I want you guys to do, put in some work. So I've given you some examples, I've told you why. Now I want to think about your project, depending on where you are. Maybe you're just conceptualizing your project, or maybe you're further along in it. But what is it that makes you, why did you come here today? What is it that makes you want to engage patients and families? What is it, you know, no one's telling you you have to, they're telling you it's a good thing to do. But think through why, and think through, you know, the kind of theoretical, what I'll help you do. Think through the practical, what will you get out of it? Think about how you would write it into a grant to show other people that this is important for me to do. Please fund me with money to do patient engagement, because this is why it's important. So I'm going to give you a couple of minutes without me talking to write down however you want. You can start out with a broad concept and then give some practicals. You could start with some practicals and then think about what that looks like when you bring it together and what it means, and then give a broad summary of like, why do you want, just answer that question. Why do you want to engage patients and families? Any other comments online?
Just while you were talking, somebody else talked about engaging to build trust in the community, which then was a word that I heard you say right after.
All right, put that aside and look at, reflect on it as I talk through this. We'll use this information in the second half of the session. But again, thinking about why, it's really going to have to connect with your long-term goal of your study, right? So overall, your entire study probably isn't around patient and family engagement. Your entire study is about something bigger and broader. But the why has to connect with your broader objectives. So on this slide, I kind of say, okay, what am I going to do here? I want to have patient-identified outcomes. That's my practical. That's what I'm thinking about. I need to get out of it. I know that my long-term goal for this study is to improve the health of children facing challenges from transitioning from hospital to home. So I'm going to think about what does it mean for me to engage patients and families? Why am I doing it specifically around engagement? And it's so that it aligns with their needs upon discharge. So we need to align specifically with their needs along discharge. We'll talk about a little more about the population, who we want to engage in a minute, but just thinking broadly, you want to have your practical, why do I want to do this? What do I want to get out of it? You want to have your overall vision for your study, and then your engagement goal needs to fall in between and connect those two things. This is the question I always get asked because everyone, I know I need to do it, but how do I do it? So how do we engage patients and families? And there's a few different ways that we can approach this. My funny cartoon is the way not to approach it is to just go and do all your work in the background, put it up on a screen and say, what do you think? Think about your experiences. You may have had similar experiences where you've worked with a supervisor and they've done all this work and they're like, yeah, what do you think? And you're like, oh, why did you do this? Why does this look like this? Those are the exact same questions your patients and families are asking, right? They are thinking in their head, but maybe they don't want to express it, is it's nice, but I don't know why you built it this way, you know? I don't know why you designed it this way because it doesn't fit with my lifestyle. They might not ask because they think, well, these are the experts. They know why they did it. But really, you want to engage with them, allowing them to know that they are the experts. Their lived experience should inform rather than you put it together in the background and then you say, hey, what do you think? And they have to try and figure out, like, what was it that related to what the needs assessment was? What was it that related to stories we told about our experiences? I don't know any of this stuff. So that's not how you engage. How we do engage, one way is, thinking about it again academically and theoretically. Academia loves frameworks and models. This is a model of patient and family engagement, or a framework to consider. And what they've done is they've taken patient engagement and put it into groupings that kind of tell you how much. So we talk about here, less time, knowledge, and funds, more time, knowledge, and funds. So this is kind of, I wouldn't say easier. It's like a simplified type of engagement to a more advanced type of engagement. And I hate using the terminology that's kind of like a ladder or a hierarchy because it's not. It shouldn't be seen that way. But when they put it in a model like this, there's the last. So there is kind of a little bit of engagement all the way to really collaborative engagement. So you can think about it as inform, consult, involve, collaborate, empower. And when we think about inform, we actually don't think about that as patient, community, family engagement. That's more around knowledge translation. That's about getting stuff out to the general public. You can use patients and families to support that work, but that is kind of just getting stuff out there. Consult is kind of, we call it ad hoc type of engagement. We have a document already. Maybe it's a consent form, maybe it's a survey. We say, what do you think? We take their input, then we go into a back room and we talk about it. Involve is like, okay, this is where we want you to help us from the beginning on deciding what the research question is. Collaborate is more, okay, thanks for telling us about the research question. Now, do you want to work on the analysis with us? Can you actually sit in a meeting and talk about analysis? And then empower is like, oh, that's your question? Okay, let's see how we can bring this to a research study. Let's really have you drive this study. This is one way to think about patient and family engagement. It is probably the most common out there in terms of methods and frameworks. But I'm going to share a different one with you, and it's just a different way of thinking about engagement. And I look about principles and values of patient engagement. So when we think about how we engage, I like to think about it as values that we want to put forward. So as a patient advisor myself, I want to know when I'm coming onto a research team that they're not thinking about me as collaborating with me, but they're truly thinking about, are they going to listen to what I have to say and incorporate that information into the study? Because collaborate isn't meaningful to me, but integrating my perspectives into their study is something that's a little more concrete. I can hold on to that. Mutual respect too, you can tell me that I'm here that you're going to empower me to partner with you, and that's great. But I want to know that you're going to respect my expertise to actually drive that forward. So thinking about values of patient engagement allows you to think about what you will do every day when you're talking to your patients and families. Will you have a value of partnership? Will you actually reach out to them when you're doing your analysis and say, hey, I want to work with you on this because I don't want to do this all myself in the back room? Will you allow them to hold you accountable by putting forward the idea that, like, if I said something that, you know, you weren't comfortable with, if you didn't feel like you could speak up in that meeting, how can we work towards that? Because I want you to be able to speak up in that meeting. I don't want you to feel intimidated by the whole bunch of PhDs we have in this room. Your voice is just as important. So what am I going to do in my meeting? How am I going to introduce my patient partners in that forum? How am I going to give them support to help with their thinking so that they can hold me accountable if they don't feel comfortable speaking? Co-learning. We're all researchers. Every research study starts from scratch. That's how it should be, right? We want to start from the basics where we don't have the answer to the question and find the answer to the question. Why can't we do that with patients and families? What is it that we can provide them in terms of understanding the literature review, understanding the body of research that allows us to start together and co-learn together? Is it a matter of walking to your first meeting together and saying, this is what I know about the topic? You tell me exactly what do you know about the topic, right? That puts you on the level platform right from the beginning where their lived experience is on par with your expertise based on reading the academic literature or conducting research in the past. But that lived experience needs to be on par if you're truly going to start with a co-learning mentality. And then transparency. So this one I love in academia because transparency is so needed in academia in everything we do, right? You know, people don't realize that a research study can take, 14 years before anything comes out of it. People don't realize that you might be funded for a grant for 1 year, but it actually is going to take 2 years to get everything done. Those sorts of things are things we need to share and be transparent with our patients and families, right? So I like to say the biggest one that we hear is, will you partner with me on this grant? Will you write a letter of support for this grant? They write a letter of support and then we ghost them for 6 months, if not 8 months, while CIHR figures out if we're going to get funded or not. And then we don't get funded. We kind of get bummed out that we didn't get funded. And then we just don't get back to them because we're bummed out. We didn't get the funding and we're not going to work with them. So that's transparency. It's also accountability because you want them to hold you accountable for getting back to you. But these things where we talk about inside baseball. I don't know if you know that terminology, but often we live so much inside that we forget that we need to translate it to those outside of what's happening, what's going on. Academia either goes really, really fast compared to the outside world or really, really slow. And we forget that the outside world doesn't necessarily go on the same timeline. So transparency. So I share these two different frameworks for patient and family engagement because I think we can use them together in terms of planning our patient engagement plan. We can think concretely about how do I want to act with my patients and families? What values do I want to put forward? And then think about what does that mean? Am I involving them? Am I collaborating with them? Do I have the time, resources, and knowledge to empower them? Or are we comfortable consulting with them because that's the time, resources, and knowledge, experience that we have with engagement? So combining these two frameworks allows us to think about things in different ways so that we have a patient engagement plan that works for us, because that's in the end what we're trying to do. So how do you want to engage patients and families? Think about the theoretical again, involve, consult. Think about what do you want to do? How do you want to feel every day when you're engaging? Do you want to feel like you are really being inclusive? You're truly partnering? Think about those things, but then also think about the practical, like who are you engaging, right? If you're engaging youth, how do you want to engage with them, right? Do you think it's really motivating to call a whole bunch of youth into the hospital to sit in a boardroom and have a conversation? Would they rather talk to you online? Would they rather, you have a lunch session at their school and they all come together and meet in the cafeteria while they're having lunch. Like, how do you want to engage with the population that you're focusing on? Okay. So I'll give you a couple minutes to think about that, write it down, and then we'll reflect on it. So again, as you write your answers down, you can reflect on this and think about, again, what kind of values do you want to practice? What kind of framework or theory are you mapping it to when you have to write it into your grant? But then also when you're describing your patient engagement methods, what are you doing with them? Do you want to set up advisory committees? Do you want to go to schools to engage youth on their lunch hour? Do you want them to draw pictures for you that you interpret together as a journey mapping or, graphic storytelling? Think about the practical engagement methods. It's okay if you don't have one, but think about what would be nice to get out of it and how's the best way to get that out of patients and family, and how do they want to share it with you? So again, we think about our values. So I want to respect my patients and families, which means I want to provide them with honorariums for their time and effort. I want to respect them by not booking 5-hour meetings that they have to find childcare for. I want to do it in a way that they don't have to necessarily travel. That is respect in practical terms. Okay. Partnership. Partnership in this example is all meetings. I don't care if it's a meeting where we're talking about boring behind the scenes stuff. I think that's valuable if they're truly going to feel like a partner. They have to hear the boring in between stuff or behind the scenes stuff because they might see that in a different light and it impacts how they're going to partner on the rest of the study, right? So if they know that, oh my goodness, CIHR takes 8 months to get back on funded, then they might say, you know what, here's your letter of support. In the meantime, I would love to book a couple of meetings with you to just explain my story to you. Listening to that and saying yes is incredibly valuable. But you wouldn't do that if they weren't sitting in that first meeting where you talked about how you got to sit around and wait for 8 months before you get funding. Co-learning. So co-learning, one aspect of it, and people are quite afraid of this at this stage, is involving patients and families in analysis. You know, we go to school to learn how to do analysis. We spend years trying to figure out that methodology. What does it mean you're going to put it in front of a family and let them do the analysis? But I do qualitative research, so we do a lot of qualitative coding. It was quite confusing to learn how to do qualitative coding, but it doesn't mean that I can't break down that framework and say what words mean something to you when you read this. If I give you these 4 words, because these are the codes we came up with, does that reflect your lived experience? There are ways that we can engage patients and families in analysis that are not burdensome, don't take years, they don't need a master's degree, but also some patients and families have master's degrees. I've worked with patients and families that have PhDs in engineering. They have the methodology. They just need the opportunity to work in health research and look at that data, right? So it's not like we can put a one-size-fits-all on all patients and families don't have enough knowledge to do analysis with us. It's thinking about what works for that group, what works for the way that they want to share information with you, what works with how they want to work with you. So again, this is all up to your project, but it's also up to you. How do you want to work? Right? I'm not going to impose a methodology on you and tell you have to do it this way, because you won't succeed. You need to come up with a methodology that allows you to be successful in terms of partnering with patients. All right, before we go on to how we're going to do this, We're about halfway. I've been yattering on for a little bit. I'm gonna just open up the floor to questions, comments, even just like, I have no idea what you're talking about. You just yattered on for 30 minutes about something.
Yes, yeah, question slash comment. First of all, thank you very much for, I guess, teaching us, informing us about such an important topic and making it so engaging. I think we all kind of want to be at that right side of the spectrum to empower the patients, the partners. But we all work within a time frame of, it could be a graduate degree, a fellowship, or just funding in general, being 1 year to 5 years, whatever it may be. Within that time frame, to build that partnership, to build that relationship, so that we are able to empower these patient partners. How do we balance, I guess, those two?
You have highlighted why I don't like that first framework. Because empowerment is not the goal. Meaningful engagement is the goal. And you can meaningfully engage at the consult level, at the informed level. You can meaningfully engage at any of those levels. So our goal is not to get to empower. Our goal is to figure out what can we do effectively with the time constraints, with the budget constraints, with our capacity to do it. Because the challenge that I see as I work with people that are doing engagement is they want to do it to the best of their ability. But they forget that part where it's the best of their ability, right? So that's what we're going to talk about. You've actually led into the next section, because as we come up with our engagement plan, a key aspect of planning is being realistic in our resources, being realistic in our time, being realistic in our money, being realistic in our capacity. If I am not someone who knows how to talk to children, I might not want to engage in the most biggest way with children and youth. I might take a skill set that I have, which might be, art or, talking, engaging, and think about how can I apply that to engaging youth and children. I might be really good technology. I know how to interact on, whatever the social media is that kids are on right now. So maybe I use that to my advantage. But it's being reflective of what we are capable of instead of something that happens in academia a lot, which is we want to show, so we push ourselves to the limit. I want you to be realistic because I want this to be meaningful for the patients and families. And there's nothing worse than extending ourselves to being the greatest people that we can be, and then failing in front of patients and families, and then not sharing and being transparent that we just failed. It's better to work up to co-learn together. So being honest from the beginning and saying, I'm new to this. Can you help me? Let's work on this together. I want this to be as important to you as it is to me. So please be honest with me. Let's do this. Does that answer your question?
Yeah, thank you very much.
Any questions online on the first half that we've been chatting about?
I was wondering more about the analysis of patient engagement, because when we talk about analysis, software-based or statistical, and then if we go ahead and talk to them, it might intimidate them, mainly if they are not in that field. And also, I was thinking practically, because there's the data sharing part, there will be ethical issues in that. So I was wondering if you can elaborate a little bit.
So you are exactly right. One of the challenges I am working to eliminate with it is, how do we include patients and families without having them to fill out data sharing agreements? I have youth, they're not university students that are undergrads at other universities, and they're working with partnership with patients and families, and they're asking these 19-year-old kids to write data sharing agreements because Queens is sharing their email address. And it's like, no, they're patients and families. They just want to engage it. So yes, there are practical considerations. And those sorts of barriers you come up with, please come and talk to me because I need to be aware of them so that I can help change the policies around them to fix them, right? So if you come up, this is just a general statement of, if you come up against practical barriers, I don't know how to compensate my partners. I don't know. That is my role here. Please come to me and I will help you support with those challenges. But I'm going to ask you to think about analysis. Once you conduct your analysis, you present your analysis, right? You know, data sharing agreements for that. We go to conferences and there's always that person in the front row that thinks they're smarter than everyone else at the conference and they put up their hand and they question your analysis and why you did it. And you are so smart, you know exactly how to get back at them and answer that question. But it's always that can be what we do with patients and families. We present the information to them as an audience. So if you're going to a conference, you present it very statistically and you show your methodology and do all that. If you're presenting it to your significant other, you might say, what'd you do at work today? I did this, you change your language and you say, well, I crunched these numbers and it kind of showed this weird outcome and I'm not really sure what this outcome is. That's a conversation you can have with your patients and families, right? You can crunch your numbers, you can do your statistical analysis and you can say, this reflects this. Does this reflect your understanding of it? So we recently did a paper, we did an analysis of the impacts of the COVID pandemic on children's medical complexity. So we looked at a whole bunch of hospital statistics and the finding was, it was another parent of a child with medical complexity and me in this team meeting. And they presented the data and we both looked at each other and said, this totally doesn't make sense. Like our lived experience is not what this data is reflecting. They walked through the data, they talked about the analysis and we said, okay, so what we assumed isn't what is reflected here. So can you make that clear? Because every other parent that's going to read this analysis is going to say, you're wrong. And we now know that they're not wrong. We know how the analysis, because we sat there and we partnered with it. So our input was not changing the analysis. Our input was, okay, we need to state that this is the assumption that patients would have, but this is how our analysis is reflecting that, but in a different way. Like we had to explain that background. That is what's going to make people read your paper as patients and go, oh, okay, so they thought through that. Right? Otherwise, we're just going to end up with a whole bunch of families that are going to be like, you so did not, you don't know our lived experience. You just crunch numbers and it doesn't make any sense to me. That's what we want to avoid. Okay, did that answer?
Yes, thank you so much.
Any other questions online? I'm looking, I can't remember where the camera is at the topic. So
It's just on top of the screen.
So yeah, anything online? All right. So how are we going to do this? Can we do this? This goes right to your question on, do we have the resources and the capabilities of it? So we need to be honest with ourselves on what we can do. I often tell people to think about writing a grant. And if you're a grant reviewer and you read someone's budget or you read someone's plan and you're like, you're not going to accomplish that in 2 years. That is not reality. I want you to think about that when you're building your patient and family engagement plan. How realistic is it for this to accomplish? And when we think about what's realistic, one of the things we have to be honest with ourselves is, what are we capable of? What are our strengths? What are our weaknesses? Right? Is our weakness asking for money? Is our weakness that we're already funded because we got a fellowship, but I didn't include any money in that for the project to do patient and family engagement. So now I'm already a little bit behind because I don't have the budget for it. That's a reality. It happens all the time.
Question online. What impact is the disclosure of personal lived experience by researchers who have a personal connection to the subject matter of their research have on their ability to meaningfully engage with patients and their families throughout the research journey?
So I fall into that category. So I'm a parent of a child with medical complexity. I am not a child with medical complexity myself. But I engage with that population because of my lived experience. There's two ways to think about it, and there's no right or wrong answer. It's a personal navigation on how you navigate this issue. I came into the research world with my lived experience versus so I was very public with who I was prior to engaging. There are some people that come into and keep their lived experience private, but they're passionate about that area. But they feel like it might hamstring them in their ability to. So if you live with a disability, I actually do live with a disability. I don't tell people because I think it's going to harm my career, right? People listening to me in terms of like, is she capable of doing this? If she, has this illness and won't be able to do this. I personally navigate my career based on lived experience differently publicly than I do. But I have to understand that if I disclose it to my researcher, my partners, it may come out other places. So that's a personal navigation issue that you have to do. But what I can say on the positive is disclosing it. When I reach out to parents of medical complexity and I say, this is important research to me because I lived it. Did you live it? Did you experience this? Did you have challenges sharing decisions with your healthcare provider? And they look at me and they're like, oh my, like no one has ever voiced this to me before. But this is someone that I trust who's walked the walk that I have. I can build a connection on it. That's a good thing or it's a bad thing. Again, it's something that you have to navigate. I found it with my population of parents with medical complexity. They're always seeking people that have a similar experience to them because we feel so isolated every other day. Okay? I never met, for the first year of my child's medical complexity, I didn't know what another trach-vented parent looked like. A parent of a child with trach-vented. Because in the hospital, I'm not allowed to talk to them. In the hospital, I'm not building relationships with them. I had never spoken to another parent who had their child on a ventilator until my child was a year old. Okay? So being able to connect on that level is something that does help build relationships. But it's different if I want to connect with someone else with my disability, my personal disability, because I'm going to navigate, they have an impact on my career. Well, again, like what are those things that I have to be conscious of? But that's basically because I had a previous career that, informed my practices around that. So I don't have a right or wrong answer. I'm just saying be aware of it and navigate it in a way that feels comfortable to you. If you feel like you're walking into a space and you're trying to connect with people and it feels inauthentic, like you're not actually the same as the people you're trying to connect with, then don't be authentic. If you feel like you are authentic, then keep on engaging and ask for feedback. Are you comfortable with me sharing that I have this? And I'm a parent of a child medical. Are you good with that? Those are things that we have to be authentic about and navigate as we learn together about how to engage patients. There are many intersectionalities with the populations we work with, right? We can say that I'm a parent of a child with medical complexity, but I grew up speaking English. So maybe someone who doesn't, who's dealing with this exact same lived experience, but through a different lens, does not want to talk to me on that same level, right? And I have to be fully aware of that and reflect on that and figure out how best to navigate with them. Maybe they do want to engage with them. Maybe they don't. I don't know. That's why I'm engaging with patients and families. Right? Help them support you to navigate that. Yep, great. I'm glad I could be of help. So how many resources do we have? Who do we want to engage? Who can we engage? I would love for every single one of my research studies to involve parents whose English is second language. But if I have no funds for translators, I can't do that on my own. Right? So do I have to justify then when I'm putting together my plan why I'm only engaging those that speak English? Yes, but that's a constraint that I have and I have to justify that constraint. But it's much better than me thinking that my population is all parents of children with medical complexity with all experiences. It's not realistic. I can't do it. The last one is really, really important. And I highlight this to you because people don't think about it often. What can we change in our research and what can we not? Okay. Oftentimes, the best example I have is oftentimes we'll come to patients and families and say, I'm putting out this survey. I'm sending it out to everyone. Can you just take a look at it and see if the language reflects lay language of, those with a grade 6 education? And they spend all this time, they look at it, they write their answers, they give you all this feedback. And then I say, what did you do with it? Oh, I couldn't actually change it. It was a validated measure that had these instructions on how to put this question together and then how to analyze it. And then we changed the wording in the question that it wouldn't be validated. So why did you ask them in the first place to give input on it? You couldn't change it. And it's fine you couldn't change it. You were using a validated measure because it gives authority to the research study and it helps you in terms of getting the information out there. They know you're using this measure. But then think about what they can change about it. What can patients and families do? Can you give them 4 measures and tell them which one's the best? They don't have to change anything, but they might be able to decide between those 4 measures, which one reflects their lived experience best. Maybe we don't change the measure, but maybe we think about how we recruit people, where we go out and get them. How do we deliver the survey? Is it REDCap, because everyone does REDCap, or is it something else, right? Those are things that we can change. So we think about what we can change and we think about what we can't change. And we're honest with ourselves and we're honest with our patients and families on what they can impact and what they can't. The reality is there is a whole process in building a validated measure. If the validated measure doesn't work and they tell you it doesn't work, you have to consider if it's bringing in a new measure or not. If it's designing a whole new measure from scratch, but that affects your timeline as you talked about. Is that realistic if you're doing a 2-year funded master's, right? Probably not. You're going to do the validated measure. Your supervisor said the validated measure. As much as your patients and families don't think it's applicable, work with them, but be transparent that this is the process of validated measure happens. What can we do around this that we can't change? Okay, so we're being open and honest with ourselves about it. So I want you to think about what can you do? What are you good at? What do you have access to already? You have access to patients and families in a subset. So I'll give you an example of how we can think about what you can do. So you might be working on a grant proposal. You might think that you want to engage children and youth from this specific population, but you don't have access to them right now. Can we talk about a plan that engages maybe people that you already have access to? Maybe there's someone in your lab with lived experience in this sort of area or engaging with them. Can we engage them to help with the grant writing? And then right into our grant, we don't have access to this population yet, but we're going to connect and build relationships with them by doing this. You're also being open and honest on the resources you need, the time you need, and how it integrates and makes your study better. But you're talking about what you can do. I can engage people right now in helping me, but I can do this to build the relationships I need to engage with them later in my study. What do you have access to? Who do you want to engage? How is best to do it with your expertise, your knowledge, your resources? The other thing that we talk about with what can you do? You're early enough in your study, or it's, you have the support of your super. If you know that this is going to cost money to engage, or you want to engage meaningfully with patients, you want to compensate them, you can apply for a grant and include that in your grant, right? That is something that you can do if you're early enough in your study, but it's important to make sure it's included in your budget. People often put everything else and then they forget the engagement budget at the back. Maybe what you can do is you work for a really big lab and there's someone in your lab that does patient and family engagement already. They're experienced. Have them, include them in your, ask what you can. Hey, you know, Carla, can you handle, if we get funded on this project, do you have time to handle the booking of 5 meetings with these patient advisors? Can you help with writing some materials so that they can understand how to do analysis with me? Can you do all that? And you negotiate that and you're like, okay, as a group, this is what we can do. But look about your supports, look about your team, look about your people. Write down what can you do? What are you good at? And then reflect that without the way you can't do. I cannot engage, you know, youth from China if I am here trying to understand their lived experience with attempting to find healthcare as they transition from another country into Canada. Like, that is not reasonable, but you might be able to engage those that have already gone through that experience. But I can't engage those that are currently in a different time. Doesn't work for me. So what can you do, what you can't? Write it all down. I'm gonna use it in about 5 minutes. One of the things that I haven't talked about a little bit was roles. You know, thinking about, you know, what kind of role, what kind of capabilities are there for your patients and families as much as the capabilities for you, right? So if you're going to engage experienced patient partners, then what you can do might be bigger than what you can do individually, right? Your patient partner, say they are part of a larger network of patient partners. Maybe they can get you connected to other patient partners. So your capabilities now are much broader, but you don't know that till you're engaging with them and you find out, right? I've been on a number of studies where researchers are like, we need to tap this population. I'll be like, oh, I have a Facebook group of like 500 of them that I engage with daily just to share ideas on how to, you know, change your child's trait ties or how do you keep them on from pulling it out. We engage on that stuff all the time. And they're like, oh, can you post and add it? I'm like, yes, we can. Like, I see them all the time. That knowledge isn't until you have that interaction. No one's asking you what Facebook groups are on a regular conversation, but in a meeting where we're talking about recruitment, that might be something that helps me understand that capability. So thinking about that in terms of what you can do and what you. All right, if we're all written down, we can give some examples. So, you know, I can apply for funding. We talked about that. I have access to advisors. We talked about that. I can change consent forms a little bit depending on, you know, what templates SickKids is putting out these days, but I can change consent forms. I can change my recruitment materials, and I can change my methodology of analysis in terms of who I have in the room when I'm doing. Those are things that what I can't do has to be done in 2 years. That's the funding. I don't have a team. It's me. I'm doing my entire PhD all by myself. So what do I need to do to keep that as top of mind in reality? I can't change my surveys, they're validated, right? Putting this down on paper and reflecting on it allows you to make decisions that take these into consideration. And that's really. All right, we're gonna take a break, grab some coffee, grab a washroom break. And when we come back from break, we're at 2:03. So we will come back, we'll give you 2:10. I think we have enough time to do break. So if you need to come back at 2:10.
Yeah.
Okay.
Makes fun sense.
So, we don't have, what I want you to know that is your.
I said I did it.
Okay.
Did you get out?
I don't know.
I'm good at it if I practice.
We have added to the but this way, what if these are like, then diet, and that's some sort of thinking that you've gone into. The other thing I want you to present a little bit too is, I think one of my parts, we talked about, the methods you're gonna do, so there are costs associated. Right, so now you have to travel with me to travel. Or what, you don't want to be out of pocket for that, so you're gonna apply for the funds from the honor. But what did you put for some costs? Meaningfully. So I want you to talk to some of those costs.
Well, it's actually.
This is the interest.
And then I should.
What are the costs?
That's the
I guess, okay.
Or.
Joel, who was here earlier, to see if he has any insight on it.
This was, I don't think it sounded like it was coming from a screen.
Everything there was normal, everything there was normal. I think it was coming from like the alerts.
Yeah,
So
I've never heard that one before.
I thought that maybe it was nothing. We did. But yeah, I don't know. We'll see if he gets back to me.
All right, so that we have time for a bit of questions, I'm gonna ask. And I went around individually and kind of expressed what you need to present. I'm not looking for anything formal, I'm looking for you to express and share with the rest of the room what your conversations were about. If you came up with a plan and you can summarize it in 2 minutes, please do. But otherwise, I want you to talk through what questions you were asking each other or thinking through to come up with an effective engagement plan. So I'm gonna start actually in the order that I went around. So I'm gonna start over here.
Yeah, definitely. So we were kind of thinking about doing. So we were thinking about creating a patient advocacy committee. So maybe you start off with like 3 patients and go 3 advocates and go towards maybe 6 advocates. And one of the things we were thinking about is how those advocates would be representative, maybe demographically, geographically, with gender. And we kind of came to the conclusion that it's not really possible to get the most representative sample, but like it's just kind of part of the process to get as many people as we can that could give their input on the study. And we're also maybe considering connecting those advisors to maybe if we have 3, maybe they would have other connections within the field to maybe connect to more. So maybe leveraging their existing, skill sets and talents and maybe, giving them extra responsibilities that they can kind of take on more of a load based on their experiences. Maybe some of them have a PhD, maybe some of them, have an extensive research background. Maybe they have a, completely different background that is a unique perspective. So, using their skill set. In terms of like holding meetings, we were thinking about maybe having something in the evenings virtually, so you wouldn't have to worry about the costs that would be associated with travel, or maybe if it's at night, then they, if they're a family, they have kids, it would be, a burden to have them have their kid in daycare during the day. So we thought that would be, the best way to have them have a meeting without as many conflicts. And then in terms of kind of budgeting compensation, we were thinking about maybe in terms of in the grant outline, we would have a % allocated for them to have a budget to give compensation for their time that they're allocating to be part of the committee.
So as you're calculating your budget, think about how many times you would meet. So how often, what is the time that will actually be taken up by the patients and families in meetings, right? So often we budget, so the standard is $25 to $30 an hour in compensation is what we tend to budget for. With that, we'll calculate if it's a committee type meeting, we'll say you meet every 2 months. Budget 1 hour for the meeting if it's an hour-long meeting. but also an additional hour for a half an hour before for reviewing agendas, documentations, pre-reads, and also a half an hour after just to say, you know, if you want to give comments and feedback and things like that. So we often do about 2 hours for every meeting, and we calculate based on what the meeting. Talk about evening meetings. Evening meetings are great for patients and families. PIs don't often like evening meetings, and you might schedule an evening meeting because it works for your patients and families, and then you will not have senior input. So your patients and families will never meet the PI because they will never show up to that meeting, right? And it's not, I'm just saying, that's the reality of it, right? Or they're at conferences or they're, so just thinking about balancing what it means to have senior leadership support the patient engagement is meaningful by ensuring that they will attend some of these meetings, have firsthand insight into what patients have been. The other thing you talked about was kind of getting your group together, representative sample. Think about other resources that you don't need to invest in putting together. It might be hard to put together a representative sample of 6 people or your group that represents your population. But, you know, there's EDI committees I can connect you with. There's an EDI table at Women's College Hospital that specifically has a view to look at research projects from an EDI perspective. You can bring your study to them and say, does this reflect diverse populations, diverse perspectives? They put the hard work in bringing the right people to the table. Depending on what populations are, you know, if you're dealing with youth, there is YCAN, which is Canada's youth, it's a group of youth from across Canada. You know, bring it to that table. If you have a few questions, bring it to that table with the support of your patients and family. But what you're doing is connecting with other people with diverse perspectives that you don't need to just create for your study. It's efficient, it's cost effective, and they put in the work to find the right people at the table. They put in the work to work with the people to make it a safe environment for them to engage in. So think about how you can partner with other groups to achieve the same goals you want to achieve, which is probably diversity and diverse perspectives, but with the support of the patients and families, you've built really solid relationships. Any questions for the team or comments or something about lived experience that you have that you can help them with their project? Is a committee the right thing? You didn't tell us actually what your goal was. Why do you want to engage patients and families? What's the objective of it in your study?
So ours was with relation to an actual project that I'm doing, and it's about the SickKids biobank for pediatric eye cancers. And one of our main priorities is to promote patient engagement in the biobank. And so we wanted an advisory committee who can reflect on and provide advice for us and their experiences as we go through the research process and actually.
Okay, we have to connect after, but I have a lot of questions. Who is your population for biobanking? Who do you want to engage?
A lot of different people are involved. It's there are a lot of different people who are involved. So specifically, we're looking probably for patient advocates or adults with a lived experience.
In what?
Eye cancer and research, or well, we have one member on our team who has lived experience, but was in like business and just provides so much information that you wouldn't really maybe think of right off the bat that we always discover at our meetings.
So biobanking is an interesting one, right? Because your population is biobanking of eye cancers.
Yes.
But the experience of deciding if you want your child's specimens stored for future research can be bigger than eye cancer, right? So it's really determining for your study, what is the right population to engage in? And for some, and I've been thinking about this because we're talking about precision child health and engagement around precision child health, the people that don't know yet that they're going to be patient, right? Because once you've engaged someone who's been through the process of biobanking, you will get that perspective. But often we bring people in and we're like, yeah, so here's your kid diagnosis, we're gonna find these tests, we're gonna pull this, we're gonna grab some stills, we're gonna have some samples, and yeah, you wanna put it in a biobank. And they're like getting all of this at the exact same time, right? So of this, we might wanna think about engaging those that have never even stepped into the door that they take in. So broader population, what do you understand about money? What does it mean to store stuff? What does it mean? So think a little more, not you, but we always have to think broader about who are we engaging, not just the people that have been exactly through what we're studying, but what are the applications to a broader population and what perspectives can they share? And that's precision child health. I have a whole project around precision child health and engagement, and biobanking is one of them because we have to think about how we get consents to actually take samples and store them for future research that we don't even know what it's going to be. All right, what discussions did you have?
My postdoc work is looking at medication use in pregnancy. So I really wanted to have a more inclusive research approach. And also among the disability community, the research about us is very important. So I wanted to, or I have developed an advisory group who will inform different research priorities. I'd like to work with them to interpret findings and then also to develop tools or KT products. So I have 3 people on my advisory group. It's really small, but we really talked about, I think, more about like the initial engagement with them. So what does that first meeting look like, and how can we use, I think, softer questions like what motivates you to be here instead of like more directly asking what's your disability, or I had some really helpful tips on meaningful engagement. We talked about budget as well. I have.
So I'm going to probe you
Okay.
a little bit about, if you want to involve them in analysis, how does that affect your time?
Yeah.
So thinking about how much longer it might take for you to run the information needed so that they can actively administer. We're running out of time and I got to look at another, but so I'm just gonna throw that today. As you think about these things, that's one thing. How does it affect your timeline? There's budgets. How does it affect budgets? But also, are we capable of engaging with them and thinking through the methodology we would use to involve them? I'll give you an opportunity in like 2 minutes to explain just your discussions and what you talked about, and maybe a learning that you want to share with the rest of the team from what you talked
Oh, sure. I think I really appreciate hearing plans because we didn't quite formalize a plan, but I think it was mostly just we were so curious about each other's experiences. We had a range of different expertise in patient engagement and involvement. We also studied different age populations, young children, adolescents, adults. So lots of conversations about our experiences and challenges and access to patients, et cetera. And the learning, I guess, is just a personal learning. I did a KT project recently and decided to do a TikTok because we were talking about where do we find patients or how do we get them, with difficult, hard to recruit populations. And so I decided to do a TikTok. It was about an adolescent health issue, which was aligned to the topic of my research. So I posted TikTok, or I did the TikTok, and then in my TikTok ignorance, accidentally posted the TikTok. And within an hour, so many people, strangers, were contacting me, wanting to research. I have my email address, loving my what I had shared. And so just an interesting creative way to think about, well, how do we find these adolescents to be on a specific research advisory while thinking about where adolescents kind of live and play while they're online a lot, and something like 83% of them use TikTok. So, try to kind of harness them where they're at.
I think that's fantastic. I think it shows marketing, but I'm going to highlight another challenge that comes out of your story, which is, do we have the resources to respond to all the comments that come in, right? So now we've done good marketing, we've got the connection, people, how do we vet them? How do we determine, is there a way to engage the broader population with like a survey? And that's one way of engaging. And then identifying through the survey, maybe a smaller group that we want to vet to maybe partner on this stuff. But it takes time and energy to respond to all the responses coming in on things. So when we're thinking of our plan, when we're thinking about it, thinking about using resources that might exist in other places, tables that have already come together, thinking about how much time it takes to engage people, if we want to use it in analysis, and how that affects our timeline, and thinking about the time and resources that it takes to actually just build those relationships with those people and identify them. So that's kind of what I will leave you with at the end. My information is up there. I am here at SickKids. I have a SickKids email address. Please email me at Francine Buchanan at sickkids.ca. There is also, I work for Clinical Research Services, which is CRS here at SickKids. There is an Ask CRS email that will always get to me as well. So if you forget my name, type in Ask CRS in your email and I will get it. I am here as your resource. So all the conversations we had today, all the kind of questions I was answering here and there, that's what I am here for. So please reach out if you're doing something. I can share resources with you. I can share existing tables with you. I can share, I can try and connect you with patient partners in our network or others that are doing similar research. You don't need to build a table from scratch. Sometimes if you're doing new things, there might be a new table that's already at SickKids that matches your needs. Don't do everything. You're not responsible for everything. I am here to support you in terms of. So thank you for having me. I hope this was helpful. I hope you can take your notes back and apply them to the research that you do every day. And whatever stage of engagement you're at, please reach out to me. I am here to support you through.
Thank you so much. Good luck in your research and your work. Actually, I'm going to do justice. Because I